Hi Liz, thanks for joining me today. We're going to talk a bit about respiratory assessment of patients, and that's something that I don't feel I've always done terribly well on the video consult, because until now I've kind of wimped out if they seem very breathless and sent people for a face-to-face assessment. But in the brave new world we face of coronavirus, that's not nowadays the safest thing to do for a patient, is it?
No, because I suppose if they've got coronavirus, they might give it to us and everyone else. And also, yeah, so we have to think about assessing more over the phone and video. And of course, video is what we're talking about here. You can do things over the phone as well, but we'll focus on video for this.
Yeah, it's like all the rules of the game have changed, and all the risk balance that we're very comfortable and familiar with is kind of turned over on its head in this brave new world.
It has, and I think GPs have definitely risen to the challenge. I mean, GPs in the last 2 weeks have basically upskilled themselves to be able to, perform video consults. And I suppose, I mean, I've done digital consulting before, and I remember chatting to colleagues a couple of years ago, and they would be like, "Well, I'm not doing that. It's not very safe, is it?" But when needs must, things are changing. So, I mean, we can talk about some of the things you can look out for
Let's do that.
on a video, and we'll be quick and snappy. And
Yes, we got feedback. Our last one was a little bit too long, so we're going to be focused today. So what do you look out for? You're doing a respiratory assessment of a patient. What are you looking for as you start the consult?
Well, the first thing I'm looking for is, how is the patient behaving? What do they look like? Looking is really, really important, and observing, because we'll pick things up. So you and I are having a nice chat. If the patient is chatting like I'm chatting, then people can only really breathe on the, well, they can only breathe on the say that again, sorry, they can only speak on the exhale. So
Oh,
people,
I never thought of that. That's
if
really
people
true.
if people can speak on and they're speaking in reasonable sentences like I am, then that suggests their breathing is kind of okay, which is basically why when we talked about asthmatics, if they say, well, they can only speak in a few words, that suggests that their breathing is more compromised. But if people can speak, in a normal way with normal sentences, that's a good sign.
Yeah, it's a really important one to document, isn't it? It's something every remote consultation with a breathless patient or somebody with any respiratory symptoms actually always document whether they're speaking full sentences or not.
Absolutely. And things like, can you hear inspiratory sounds like stridor, that sort of noise, because you'll hear that when they take a deep breath. You might hear wheeze as well, which is an expiratory sound.
And how does wheeze come across on the video?
Probably not as well as stridor.
No, stridor I have heard over the video, and it does come across very clearly. And a top tip is, if it's a child, actually get them to put the camera phone or just a phone by the child's mouth, and you often can hear it quite nicely. Wheeze, I've never been quite convinced by, because it's quite a lot softer, isn't it? It's like, oh, is it just a crackly line, or is it wheeze? So I guess it's putting it together with the rest of the clinical presentation and sort of weighing up the possibilities.
Absolutely. And then you can look at things like colour. I saw somebody last week who had blue lips. That wasn't over a video. But what I would say is, if you are consulting with a video, it's really, really important for the patient to be in a good light, because you can get this thing where it looks a little bit like Crime Watch, where they've kind of blurred the person out and they just look like a black shape, and you can see the light behind. It's really difficult to actually see what's going on. So I think natural daylight is best myself. Obviously, if it's late at night, you can't do that so much, because the domestic lights tend to have a bit of a yellowy tinge to them, don't they? So natural daylight, ask the patient to remove, thick clothing so that you can actually see what the chest is doing. Because if someone's got a hoodie on and they've got other stuff and a neck warmer and that kind of stuff, it can be difficult to see.
I'll just pause you there about the light and demonstrate just how crucial it is. So I've actually got a UV light on and my normal lights. If I just turn them off, suddenly my colour changes and it would become an awful lot harder to assess me. So it really does make quite a big difference.
It does.
Pop the lights on again.
It does.
Yeah, so you get them to take their hoodie off. How well can you actually see chest movements? Because I often struggle with this with the bandwidth we often get on video calls. How have you got on with that?
Well, I think if someone's breathing normally, generally they're not really using their upper chest muscles so much. They're using their diaphragmatic muscles or muscle. So it's more of a kind of an abdominal breathing, the kind of moving deep breath in and stomach goes out, breathe out, stomach goes back in. If people are using their upper chest muscles a lot, that suggests that there's a degree of change in the breathing. I mean, we know that anxious people use their upper chest muscles a lot more, and you'll sort of see the muscles kind of moving, or you'll see the scalenes in the neck tensing. So you can certainly see muscular activity up in the neck.
And actually that might be a better place to look than between the ribs, where those smaller muscles you're less likely to see.
Yes, absolutely. I think the key is going to be how well can the person communicate with you. Are they making sense? Is there a degree of confusion, I should say? And then you've got the respiratory rate. It's a good idea to have an idea of all the. There's loads of guidelines out there at the moment, and they're changing every week. So it's a good idea to have an idea of the normal respiratory rates in various ages. And whatever your particular guideline du jour is, which is changing. I know there's a lot of guidelines coming out that are based on the news score, which is thought to be less accurate with COVID. So there's a lot of change at the minute. But having an idea of respiratory rate is important. It's very
and so in terms of getting that respiratory rate, Liz, how do you do it? 'Cause something I find quite helpful is if there's somebody else there, getting them to count, because I think people find it quite hard to count their own respiratory rate, and the minute you kind of ask them, they then get really conscious about their breathing, and they're more likely to hyperventilate.
Yes,
whereas saying to somebody else, I'm going to start timing now, can you see every time they take a breath in, start now and stop counting when I tell you. And actually that, for me, I found more effective than getting the patient to try and count it themselves, or trying to count it myself when the video quality isn't all that good.
That's a really good point. I think I'm doing it a couple of times. I think is really important, actually, because people will either hyperventilate or they won't breathe normally, or they'll stop. I mean, kids quite often stop breathing, don't they, for a bit when they're. It's quite a common thing when you put the stethoscope on their chest. So certainly, getting it from someone else would be useful, or failing that, getting it from the patient while you time and tell them when you're stopping. Or you could get the patient actually to do something else, like maybe read or just distract themselves from you. And
but that's a good idea, because if they're reading and you can count when they're breathing in, that's a lot easier than trying to see it.
So it kind of reduces the performance anxiety, doesn't it? But then I guess if they really are breathing very fast, you will see it from the other signs, how well they are able to have a conversation. And then I guess we move on to things like the Roth score, which I'd never heard of 2 weeks ago. But
no, nor me. And it's kind of already, since never having heard of it, suddenly it was flavour of the month. And then there was an article saying, oh, well, it wasn't really properly validated. And I think there's quite a lot of confusion, but actually there aren't many great tools at the moment, are they? So it might not be perfect, but it's probably something worth thinking.
Hello everybody, we're all triaging loads of patients on the phone now to assess COVID-19, and I thought I'd do a quick video to help you with a very helpful test called the Roth test. This test is named after a doc in Israel who's very clever, who did some interesting research trying to remotely estimate a patient's oxygen saturation. In essence, you ask them to count from 1 to 30 in their native language and measure two things: what number they get to, and also how long it took them to get there. Do it quickly but clearly, and see if they can do it in their native tongue. Now, I'm a Welsh speaker, but today, for once, I'll do it in English. So here goes. So take a deep breath in and go. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. So glad to say breathing's fine, and got to 30 and got it in 9 seconds. So if I was very short of breath, I could present this way. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and I got like 8 or 9 or 10, and you'd measure the time you took to get there and what number I got to. So the research that this guy did is really interesting. If the maximum number they got to was less than 10, or the counting time was less than a total of 7 seconds before they had to take a breath, we can guess that the oxygen saturations are less than 95% with a sensitivity of 91 and 83% respectively. If the maximum number they got to was less than 7, with a counting time of less than 5, then we can guess the SATs are less than 90 with a sensitivity of 87% and 82% respectively. So look, it's not perfect and it's not as good as a SATs Pro. It's not going to replace that, but it's definitely something else to consider in part of remote evaluation. It's an extra facet, it's an extra bit to decide, can you manage this patient remotely or do you have to bring them into clinic? Anyway, good luck everyone and hope it's of help. Thank you.
Ask.
In actual fact, Groupon had some on pulse oximeters for £11.
Wow.
And Amazon have got
Recently.
some on. Sadly, the delivery date is about mid-May. So at the moment, so methinks that people are buying these.
Yes. Yeah.
You know, if the pulse oximeter app turns out to be any good, then perhaps people can download that, you know.
That would be, I mean, that would be a game changer, wouldn't it?
Yeah.
That really would.
Yeah, especially with all the information that's coming out now that's sort of saying, you know, don't look in people's throats, don't listen to people's chests, you know, look at their respiratory rate, SATs, that kind of thing. So
and actually, that's a really important point, I think, Liz, because I'm used to wimping out with breathless patients and bringing them for a face-to-face. But if we're not going to be listening to their chest anyway, you have to ask how much value it will add when you've got all the information from the history. You've got your assessment. Are they speaking in sentences? Are they confused? And of course, remembering to ask about other markers like urine output and that sort of thing. Hopefully getting a history from a third party as well as to how they feel they're doing. We're not really going to be adding that much more with a face-to-face assessment, especially if we can get some rudimentary obs as well.
This is true. This is true. So I think for me that just about wraps it. So
Brilliant.
It's shorter than the last one.
Excellent. So I'm going to end the recording there, but please do put comments in the comments section because things are changing all the time. We're recording this on the 29th of March. She says, looking at the date on her computer, next week there's bound to be a whole different set of guidelines, hopefully a bit more information as to validation of the Roth score, and we'll have to come back and revisit this soon.
And
Thanks,
hopefully
Liz.
we'll be open soon.
Yes. Bye.
Bye.